welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website. For this week's episode, we have a special collaborative effort between AEMP and the ACCP Emergency Medicine PRN. This will be a journal club debate on discussing the preferred fibrinolytic for massive pulmonary embolism.
I'm going to go ahead and get this meeting started. So my name is Allie. I'm currently serving as the chair of the education committee for AMP. And today we will be launching our first journal club webinar series with ACCP EMED PRN. So super excited about this series. It's the first one. If you guys have any feedback after today as far as things that you'd like to see done, if you want to point out that there was something you really liked or something you didn't like about it, areas of improvement, please let us know, because we want to make this the best presentation for everyone who's able to join us. I know we're all really busy, so truly I appreciate you guys taking the time to join us today. And I want to say a special thanks to Christian Kroll from ACCP, who has helped our organization launch this series. Just so everyone's aware, this will be recorded, so we'll send this out afterwards. And then it will also be turned into a podcast for Spotify, as well as available on YouTube, I think within the coming week or so. So look out for that, and feel free to share with your colleagues if they weren't able to attend today. And with that, I will pass it over to our moderator, Dr. Judah Brown.
Hi, everyone. Thank you all for joining. As mentioned, my name is Judah Brown. I'm an emergency medicine clinical pharmacist at New York Presbyterian in Columbia, and it is my pleasure to moderate this excellent debate today on the battle of Tenecteplase versus Alteplase for the management of massive pulmonary embolism. We have two excellent presenters today, Dr. Cecilia Schowe and Dr. Natalie Pettit, who will be battling it out and providing us the best available evidence to support each of their cases. Before we get started, we will post a quick poll to see what your current practice is like at your institution. So we will see how this turns out after we present the data.
Hey, thanks everyone for joining. My name is Natalie Pettit. I'm the current PGY2 in emergency medicine at UIC, and I'm happy to present on this debate with Cecilia. Just before we get started, I'd like to give a quick shout out to my mentors for this project, Dr. Drew Posen and Dr. Renee Petzel-Gimbar, for their help with this. With that, our objectives are briefly discuss the background of pulmonary embolism and our treatment options we have available, and then we'll dive into two articles a little bit deeper for the use of either Tenecteplase or Alteplase for massive pulmonary embolism. So pulmonary embolism, we all know, is a blood clot in the lungs that often stems from a DVT and travels up to the right heart and then into the pulmonary circulation, which disrupts blood flow, gas exchange, and patients can present in a wide spectrum, either from asymptomatic to cardiogenic shock. We have a couple of different ways to classify PE: low risk, intermediate risk, or high risk, or submassive or massive, depending on the guideline body you look at. But essentially, these all take into account a few different variables when classifying someone's PE. So first off is hemodynamic instability, defined as a blood pressure, systolic blood pressure less than 90, or the use of vasopressors or cardiac arrest, or persistent hypotension with a systolic blood pressure of less than 90 or a drop of 40 or more for prolonged more than 15 minutes. The PESI, or Pulmonary Embolism Severity Index, is a screening tool used to classify the 30-day or in-hospital mortality of someone presenting with a pulmonary embolism, and takes into account the patient's age, sex, past medical history, and vital signs on presentation. So the more points you score in the screening tool, the higher your 30-day mortality, with a class 1 being a mortality rate of about 1% and a class 5 being upwards of 25%. Right ventricular dysfunction also indicates more severe pulmonary embolism that can be identified on bedside echo or with your CT-PE scan. And then markers of myocardial injury, such as an elevated troponin or BNP, can classify a more high risk or intermediate risk pulmonary embolism. So if any patient presents with hemodynamic instability, they automatically get the classification of high risk or massive PE, versus those without the shock are classified in intermediate risk or low risk, and then markers of right ventricular dysfunction or that myocardial injury places you in that intermediate risk or submassive group. We have some guideline recommendations on the treatment specifically in massive pulmonary embolism. So first, from the American College of Chest Physicians guideline, recommends systemic thrombolysis for patients with hypotension, so our high-risk patients, or those who deteriorate after starting anticoagulation therapy, but both of these are weak recommendations. The American Society of Hematology guidelines also recommend systemic thrombolysis for those with PE and hemodynamic compromise, again, are high-risk patients. And they do make a recommendation for those with submassive or intermediate risk patients, is more of a risk-benefit discussion for younger patients or those with low risk of bleeding. Some other options for pulmonary embolism that won't be discussed today are thrombectomy or catheter-directed thrombolysis or ECMO. Now, looking at our agents that we'll be talking about today, Alteplase and Tenecteplase. So Alteplase is a second-generation thrombolysis or thrombolytic, and Tenecteplase is a third-generation thrombolytic. Both of these are serine proteases that bind to fibrin in the thrombus and convert plasminogen to plasmin to facilitate breakdown of the fibrin clot. And Tenecteplase was engineered to have a 15-fold higher fibrin specificity than Alteplase, which is theoretically making it more specific to fibrin and have less bleeding risk. And it has also been engineered to be more resistant to breakdown by plasminogen activator inhibitor than Alteplase, so making it have a longer half-life than Alteplase. Looking a little bit more at our agents, so Alteplase has an FDA-approved indication for pulmonary embolism, where Tenecteplase use in this indication is off-label. The dosing varies slightly, so for Alteplase, it can be broken down into patients with high-risk PE, but those with a pulse and without a pulse. So in our patients with a pulse, the dose is 100 milligrams over 2 hours, or you can give a 10 milligram bolus upfront, followed by that 90 milligram infusion over 2 hours. And there have been some studies to look at half dose for this indication as well. In cardiac arrest, the dose is 50 to 100 milligrams given IV push over 2 minutes, and then continued CPR for at least 15 minutes after that. And you can see the half-life of Alteplase is relatively short with 5 minutes. However, the fibrinolytic activity persists for up to 1 hour after the infusion is stopped. For Tenecteplase, there's no established pulmonary embolism dosing recommendations, so they are using the acute myocardial infarction dosing, which is a weight-based dose. So for patients less than 60 kilograms, the dose being 30 milligrams. And then for every additional 10 kilograms above that, you add 5 milligrams to the dose with a maximum dose of 50 milligrams. And the dose is the same for patients both with a pulse and without a pulse in the setting of high-risk pulmonary embolism. The half-life is longer, anywhere from 90 to 130 minutes, and again, it's given as an IV push over 5 to 10 seconds for all indications. And both of these agents are manufactured by Genentech, and the pricing is about the same, both about $10,000 for the full either 100 milligram vial for Alteplase or 50 milligram vial for Tenecteplase, which is a good resident salary chunk. But Tenecteplase, I was just talking to our hospital, it's slightly cheaper. And with that, I'll turn it over to Cecilia to present our first article.
All right, so our first study, which is going to support essentially the use of Tenecteplase in these patients for massive pulmonary embolism, is called Mortality Outcomes with Tenecteplase versus Alteplase in the treatment of massive pulmonary embolism. So the purpose of this trial was to compare the safety outcomes compared to Alteplase versus Tenecteplase in our patients with massive pulmonary embolism. The authors hypothesized that patients who received Tenecteplase would ultimately have similar mortality at 30 days, and then Tenecteplase would reduce the rate of major bleeding events. Look at the methods of the studies. This was a multi-center registry study that was done from January 2012 to July 2023, so just over 11 years worth of data. And this was conducted through the TriNetX database, which is essentially just a global health research network that provides de-identified data from a number of healthcare organizations kind of across the United States. So it includes approximately 96 million patients within 57 healthcare organizations, so pretty well represented throughout the United States. We look at inclusion and exclusion that the authors used for this trial. Their inclusion criteria was patients who were 18 years of age, who were diagnosed with a pulmonary embolism, and they utilized the ICD-10 code for pulmonary embolism. And then they looked at patients who received either TNK, Tenecteplase, or Alteplase. They had no predefined exclusion criteria, but as we'll talk about later, there were a few patients they did end up excluding. And then ultimately, they placed patients into one of two cohorts. So cohort 1 was a PE diagnosis that was then treated with Tenecteplase within 7 days. And then cohort 2 was a PE diagnosis that was treated with Alteplase within 7 days of that diagnosis. Looking at outcomes that they were looking at, one, their primary outcome was specifically mortality, so on or after the first day of diagnoses for up to 30 days. So essentially a 30-day all-cause mortality. In terms of safety outcomes, they were looking at rates of reported ICH or intracranial hemorrhage and then reports of major bleeding. Given that this was a registry study and they weren't able to analyze all patient charts to really identify major bleeding, they defined this by the frequency of any blood transfusions. When looking at statistical analyses, statistical significance was set at a two-sided alpha and a p-value of less than 0.05, and then all results were reported as risk ratios with 95% confidence intervals. They did do propensity matching to help decrease the risk of some confounding variables, given, as you'll see, the number of patients that received Alteplase was a lot larger than our Tenecteplase group. They utilized things like age of PE diagnosis, race and ethnicity, sex, and then past medical history. So things like hypertension, diabetes, heart failure, and previous cardiac arrest at baseline. They also looked at things like anticoagulation use with either heparin or enoxaparin and propensity matched based on anticoagulant use. And then specifically looked at patients with a systolic blood pressure less than 88, and then those with an oxygen saturation less than 88%, to try and look at patients that were a little bit worse off or maybe more severe at baseline. In terms of enrollment, they did note that they had a number of patients that were excluded due to the outcome occurring essentially at a time prior to the indexed event, or given that it was a registry study, they weren't always able to identify whether the PE or maybe the ICH occurred at the same time, just because of the way the data was reported. So they did have to exclude a number of patients for this. They did note no patients were excluded on the outcome of mortality. So essentially no patient died at exactly the same time the PE was occurring, and they weren't able to identify that. But they did note that 18 patients in cohort 1 and then 10 patients in cohort 2 were excluded on the basis of the ICH outcome. And then as far as frequency of blood transfusions, 16 patients in cohort 1 compared to 26 patients in cohort 2 were excluded. And so ultimately, you can see here, they had originally identified 285 patients that were treated with TNK compared to 22,000 patients that were treated with Alteplase. And so then once they did their propensity matching to identify and group patients, they had 283 patients per group. When looking at baseline characteristics, I've listed here the before propensity matching and then after propensity matching. We'll focus more on the after propensity score matching. But as you can see before in the propensity score matching, they're pretty different between groups, likely just due to that number of patients, differing number of patients between groups. But on average, after propensity matching, most patients were about 60 to 63 years of age, with just under 50% being female. As far as past medical history, no major differences between groups after propensity matching. And then specifically looking at our anticoagulant use, so slightly more patients in our Alteplase group utilized heparin with about 60% compared to 53% in our TNK group, but not statistically different. And then about 16% of patients in both groups received enoxaparin before fibrinolytic. Additionally, when looking at some additional baseline characteristics, you can see the reported oxygen saturation in our after propensity score matching. So not different between groups, but about 65 to 70% between the groups, specifically looking at patients that had that 0 to 88%. About 28% of patients fell into that group within both the TNK and the Alteplase group. Specifically, the mean systolic blood pressure was about 95 in both groups, with about 26% of patients falling in that less than a systolic blood pressure of less than 88, potentially more of our massive risk patients. So when looking at the results that the authors reported, they really only had the one main result, so mortality, and ultimately they found no difference in mortality when looking at our TNK and our Alteplase group. So 19.4% in the TNK group compared to 19.8% in our Alteplase group, and this is not different between groups. Specifically, when looking at our safety outcomes of ICH and major bleeding, the authors noted that they were unable to actually analyze this due to it being less than 10 occurrences in each group. And this is really kind of a limitation of the registry study, is that due to the numbers being so low, they didn't report since they were less than 10. So it could have been 9 in each group, or it could have been 9 versus 1. We just don't have that data. And so the authors concluded that in this large retrospective multi-center study utilizing this real-world evidence, they found no difference in mortality, but that ultimately there were too few incidences of this intracranial hemorrhage or blood transfusion to really analyze between the two thrombolytics. And they concluded that further studies are likely needed to really determine our optimal dosing strategies that of TNK that we're using for this treatment of massive PE. And so that brings us to our critique. We'll talk through some strengths and limitations of this study. I think some major strengths are, one, it was a large real-world data set across 57 healthcare organizations within the United States, so pretty generalizable to our true patient population. I also think it's a strength that they propensity matched to help control for some of those confounding variables. As you saw in the baseline characteristics before that propensity matching, groups are not very balanced. And so I think propensity matching and helping trying to get even groups is a strength. I also think using a patient-centered outcome, such as mortality, helps get to the real outcome that we're trying to prevent here and prevent in patients. And so I think looking at something like mortality as a primary outcome was a strength. Also, low rates of ICH and major bleeding, though they didn't report the actual incidences of these, we do know there's low numbers between groups. Of course, there are some limitations to note and talk through. So this was a retrospective review. And so we don't really have the individual patient characteristics, given that it was retrospective and a registry study. So we're missing a lot of those key characteristics and patient factors that we would like to be able to analyze in a study looking at pulmonary embolism. We also don't have any data on the dosing that they use for these patients. Probably safe to assume that in TNK, they use that STEMI dosing that we typically use for PE. But as far as Alteplase goes, we have anywhere from our high dose to our lower dose, that 50 milligram dose. So we don't really know exactly what they were doing for these patients. I also think definition of massive PE that they ultimately use, especially in their title, saying these are patients with massive PE, they really only had about 26% that had a systolic blood pressure less than 88 or that persistent hypotension. So I don't know that all of these patients were truly a massive PE patient population. We also don't have data on other therapies provided, so things like mechanical thrombectomy or catheter-directed thrombectomy, so we don't really know how those potentially influenced outcomes and mortality. And then we don't necessarily have any data on absolute or relative contraindications that patients may have had. So with acute ischemic stroke, our contraindications are pretty set in stone, whereas depending on whether it's a massive or intermediate risk PE, our contraindications can blur just a little bit. And so that kind of brings us to why Tenecteplase over Alteplase. So I think especially in this study, they showed similar rates of mortality as compared to Alteplase. And as we'll talk about, a lot of our other studies too for different disease states have shown non-inferiority with TNK. So it's shown non-inferiority and potentially superiority in other disease states. And so I think that's kind of a strength for using it in our PE patients. Also, there's been mixed results on rates of bleeding with Tenecteplase. The second study we'll talk about maybe showed higher rates of bleeding. If you look at other studies that have used TNK versus Alteplase that we aren't talking about, they reported rates of major bleeding in 8% in the TNK group compared to 6.9 in the Alteplase group. So these rates of major bleeding are really inconsistent between groups. And so just saying because one study had higher bleeding doesn't necessarily mean that all patients will. I also think easier dosing regimens with TNK. We have a pretty set in stone dosing regimen, especially for now with utilizing our STEMI dosing, whereas Alteplase, there's 5 different dosing regimens that you could utilize that are all going to have different rates of bleed. I also think potentially decreased risk of medication errors if we have one thrombolytic that's used on formulary. If you have both thrombolytics on formulary, the risk of potentially utilizing the wrong one or utilizing the different dosing regimen is potentially higher. And then potentially a lower cost with utilizing TNK compared to Alteplase is also another strength to utilize it. I do think there's some considerations to know and things that we might need to consider when utilizing TNK and PE is potentially the optimal dose, with some studies showing maybe higher bleeding. potentially utilizing a different dose than our STEMI dosing, maybe more of a stroke dosing in these patients to still get efficacy and safety outcomes. And then also looking at contraindications in these patients and specifically which patient populations we're choosing to use this thrombolytic agent in.
Right. And then I just have a few critiques of Cecilia's article. Again, she mentioned that because it was a registry database, individual patient records were not viewed for the outcome analysis. Authors noted that the patients had to be treated to meet inclusion criteria were treated within 7 days of PE diagnosis. Well, there's no established timeline like we have for acute ischemic stroke within that 4.5-hour window. There is guideline recommendation to treat with systemic thrombolysis within 48 hours, and some bodies go to say within 8.5 hours for best results. Also, Cecilia mentioned the oxygen saturation is not part of that high-risk criteria. While it might indicate a sicker patient, it does not quite fit the definition, which in their title they said, looking at massive PE patients. Authors also excluded patients with intracranial hemorrhage and blood transfusion outcomes that they noted in their database because, quote, the outcome and index event occurred within hours of each other, and they could not distinguish which event occurred first. But I think we know which event likely occurred first based on this criteria. Again, the rates of hemorrhage were too low to analyze or report in absolute numbers, but had they included those patients they originally excluded, we might have met that 10 patient threshold to report some sort of difference between groups. Again, weight and dosing were not collected. TNK for this indication is being used as a weight-based drug. So as pharmacists, I think it's prudent that we assess the dosing used. And their overall mortality was relatively low for massive pulmonary embolism at about 19% in both groups, which is more suggestive of our intermediate PE mortality rates. And then, although they did their best to propensity match the patient cohorts with 20,000 subjects in the one group and 300 or so in the TNK group, I'm a little skeptical that there are stats good enough out there to equalize the patient cohorts. And now moving into our second article, which I will present in the argument for Alteplase, which is titled Tenecteplase versus Alteplase, a comparison of bleeding outcomes in massive pulmonary embolism, also known as the TACO PE trial. This was published by Crawford and PharmD colleagues in Annals of Pharmacotherapy in August this past year. The author's background for this is that TNK is non-inferior to Alteplase for acute ischemic stroke and is the preferred agent for acute ischemic stroke at this institution. And they were wanting to limit to one thrombolytic on hospital formulary to prevent medication dosing errors, where they noted some of their sites do not have a pharmacist on site all the time, and to limit cost as well. However, they did note that there's limited data comparing Tenecteplase to Alteplase for massive PE, so I applaud the authors for taking it upon themselves to figure this out, which one's better. So their purpose was to compare the incidence of bleeding in massive pulmonary embolism patients before and after formulary thrombolytic change from Alteplase to Tenecteplase. This was a retrospective observational cohort study at a 21 hospital health system serving Eastern Tennessee and Southwestern Virginia from October 2020 to May 2023. And they broke their cohorts up as follows. So from October 2020 to the end of October 2022, Alteplase was the thrombolytic of choice on formulary. And then in November, starting November 1st of 2022, they changed to Tenecteplase. So the Tenecteplase cohort was November 1st to 2022, and then they looked at patients to May 2023. They included patients that were 18 years or older and received a thrombolytic for suspected or confirmed pulmonary embolism with right ventricular strain and hemodynamic instability or cardiac arrest. And patients were excluded if they were pregnant or incarcerated. And patients were followed for the duration of their hospitalization. Their primary outcome was major bleeding defined by the International Society for Thrombosis and Hemostasis guidelines, which is over bleeding that is fatal, hemoglobin decreased by 2 points, 2 or more units of blood product given, or bleeding at a critical site. And their secondary outcomes included symptomatic intracranial hemorrhage, which authors defined as blood on brain imaging, and a decline in neurostatus. They also looked at in-hospital mortality, reversal agents that were given, patients who received massive transfusion protocol, and then hospital and ICU length of stay. So looking at our baseline characteristics, so they ended up with 20 patients in the Alteplase cohort and 24 patients in the Tenecteplase cohort. The average patient was about 61 years old and a good mix, male versus female, and about 90 kilograms-ish, with most patients having hypertension and either were active or a former smoker. For the indication of thrombolytic given, about 38% of patients in the Alteplase cohort and 50% of patients in the Tenecteplase cohort had a confirmed PE, and a majority of patients in each group did suffer cardiac arrest, with 2 patients in the Alteplase cohort achieving ROSC and 7 in the Tenecteplase cohort achieving ROSC. Authors also noted that heparin can play a factor into their primary outcome of major bleeding. So patients who received heparin pre-thrombolytic in the Alteplase group were about 20% and then 29% in the Tenecteplase cohort. And then those who received heparin post-thrombolytic was 33% in the Alteplase cohort and 50% in the Tenecteplase cohort. So looking at the dosing used, so authors followed the dosing that we discussed earlier, with the median Alteplase dose given just shy of that usual 100 milligram dose. And then patients in the Tenecteplase cohort, the median dose was 50 milligrams. However, they did note that 5 patients in the Tenecteplase cohort received a reduced dose based off weight dosing guidance, but they did not say what this dose was or what the reduced dose was. And a majority of patients in each group were administered the thrombolytic post-arrest. Now, looking at our outcomes, again, our primary outcome of major bleeding was 1 patient in the Alteplase cohort and then 4 patients in the Tenecteplase cohort, with 1 patient in the Tenecteplase cohort meeting that symptomatic intracranial hemorrhage criteria, which again is blood on imaging and a decline in neurostatus. For in-hospital mortality, 15 patients of the 20 in the Alteplase cohort and then 20 of the 24 in the Tenecteplase cohort died during their hospital stay. Looking at our reversal agents, so more patients in the Tenecteplase cohort received cryo, transexamic acid, blood products, and massive transfusion protocol compared to our Alteplase cohort. And then the Tenecteplase cohort also had a longer ICU and hospital length of stay compared to Alteplase. And authors did note that the relatively small sample size did not allow for them to do statistical analysis. So these are all just descriptive statistics. So the author's conclusion of this article was that TNK demonstrated a clinically significant increase in bleeding when used for massive PE compared to Alteplase, resulting in a formulary change back to Alteplase for massive PE. So just moving into my critique of this study, I thought it was a unique study design that the authors took upon themselves to answer this question and settle the hot Twitter, blue sky, social media debate that is so prevalent and why we're all here today. And then our mortality rates of 75, 85% more match mortality rates with high-risk PE and cardiac arrest associated in other studies. So it demonstrates that these were truly like massive PE patients we are looking at. Some limitations: it is a retrospective single center, although it was 21 health systems in the health system, it was all within the same health system. Again, a very small sample size and not enough for comparative statistics. Only half of the patients had imaging confirming the PE, but as we know, sometimes these patients can be too acute to get them in a scanner or do a bedside echo. So I think this is pretty generalizable to patients that we see in the ED. And while they noted the heparin or who got heparin, it's unclear how that factored into the bleeding, as anti-10A or APTT levels were not reported in these patients. Some additional thoughts that I had: while they noticed more clinically significant bleeding in the TNK cohort, it begs the question, is this related to the dose? Because this is There's no established dose for massive PE or PE in general for the use of Tenecteplase. And then given its longer half-life, is there some considerations we should take into when to start anticoagulation after TNK administration? And there was more ROSC in the TNK group, 7 patients compared to 2 in the Alteplase. However, others noted that no patient who experienced cardiac arrest survived to hospital discharge. So my overall thoughts of why we should keep Alteplase over Tenecteplase for use in massive pulmonary embolism. Again, there are mixed results on the rates of major and minor bleeding with Tenecteplase compared to Alteplase. No established dosing regimen for Tenecteplase and pulmonary embolism, and we're using the STEMI dosing guidance. And that requires knowing a weight for the patient. And just in my very few months of being an emergency medicine pharmacy resident, I can't even count how many times we're asking each other, how much do you think that patient weighs, or the bedside scale or the bed scale isn't working, and you're just guessing. So it's not, ideal to not have an accurate weight for this indication, given the high risk of the drug. TNK has shown non-inferiority compared to Alteplase for other disease states. It hasn't shown its superiority yet. And evidence, well, actually mixing up the drug and administering it, evidence supports that there is actually similar administration time between Alteplase and Tenecteplase, and that was in a recently published article earlier this month that was at Yale New Haven Hospital that saw no difference in the time to administration with Tenecteplase versus Alteplase. And then we also have maybe a patient population where TNK is maybe harmful. In the PITHO trial, which compared Tenecteplase plus heparin to placebo and heparin in intermediate pulmonary embolism, they saw significantly higher bleeding rates in patients greater than 75 years of age. So this might not be a population to consider TNK for.
Some kind of critique of Natalie's article and just reasons why maybe it shouldn't justify using Alteplase in PE. They had a pretty small patient enrollment, only about 40 patients. And it also was a single center retrospective review. So again, only one health system, very small number of patients, and pretty limited generalizability to potentially our whole patient population. Also, I think a lack of variables collected that can potentially increase bleed risk. So again, they might have shown slightly higher bleed in our TNK group, looking at some of those other variables that may have factored into them having a potentially increased risk at baseline. They also only found one case of actual intracranial hemorrhage. The others were just defined as major bleeding, which, as we saw in the definition, could just be a drop in hemoglobin of less than 2. So potentially maybe these patients didn't have as big of a bleed or a major bleed than we think. And then also just this rate of bleeding is not necessarily consistent between trials with Tenecteplase, especially in a lot of our stroke trials and even some of our other pulmonary embolism trials. The rates of bleeding have been no different compared to Alteplase and our Tenecteplase groups.
All right. Thank you both for such awesome presentations supporting or refuting the use of Tenecteplase or Alteplase for massive PE. As stated previously, I think this is a timely discussion as many of us are going through these conversations with our teams in order to provide safe and effective medication therapy. So I guess we'll get right into it, and hopefully we can continue this debate a little bit more. But I guess the first question is, based off of the evidence that you both presented, why do you think that there's been such a delayed uptake in the use of Tenecteplase for the management of massive PE? I think, as we said earlier, many institutions are converting for other indications, and it seems like there may be some evidence to support its use. But why do you think that there's a significant delay here for PE?
Yes, I can take this question first. So I think the biggest reason that comes to mind is the dosing strategy. So again, there's not an established dosing regimen. And just some thoughts that people have had on this is how the drug is getting to the site of action. When given intravenously, the lungs see the full cardiac output, and thinking that maybe this dose is potentially too big, is that contributing to higher rates of bleeding? It's also a bigger surface area, so it's a kind of complex question to consider, versus as it's used for in STEMI, that the coronary arteries only see 5% of cardiac output with up to that 50 milligram dose. And if so, that's what they use it for. So I think the biggest issue is just how to dose this drug for this indication, and there's just really not enough data to support a good dosing regimen. I think at baseline, we do have data to suggest similar efficacy, but from a safety standpoint, just not enough data to confirm one over the other.
Yeah, I think I can echo kind of what Natalie said. I think really the biggest reason is one of the first trials looking at Tenecteplase was the PITHO trial, and like our intermediate risk patients which showed a potentially higher risk of bleeding. And so I think that kind of maybe lagged behind then the data looking at Tenecteplase in this patient population. And so I just think with the number of studies being a smaller number of studies that have looked at comparing Alteplase to Tenecteplase, I think that's probably contributed to kind of why health systems have maybe held off on utilizing this agent for like both patient populations.
Yeah, and secondarily to that, and I think you both alluded to this, like we're using this off-label, we're using dosing sort of extrapolated. Do you think that given Alteplase has an FDA-approved indication for PE, does this make it the safer, better choice? Do you think that is rationale that we should use when going to our institutional committees for considering one agent over the other?
I can answer this one first. I think it definitely probably plays a role into consideration, given it is the FDA-approved agent, but I don't think that necessarily should dictate kind of which agent we're adding to formulary. I think if we only looked at FDA-approved agents, we would all have index on formulary, and we know we all don't have that. So I think while FDA formulary might be important, I think it's really looking at the primary literature and kind of seeing what we're seeing there versus just necessarily looking at the FDA approval.
I think that given its approval indications, just states that we do have the data to support its use, and if it's not broke, don't fix it. I also think that we probably will never see a trial by, a manufactured sponsored trial from these two agents because they are produced by the same thing, unfortunately. So yeah, I think in the future, this is all we have to compare. And if we get other institutions doing these types of trials, maybe the data will present itself. But for now, I think, Alteplase kind of runs itself the safer agent. So that's why I will choose to keep Alteplase on formulary for this indication.
Cool. And I think you both spoke on this a little bit previously, but a lot of our data surrounding the use of Tenecteplase is in alternate patient populations, whether that be an intermediate risk or submassive PE, where we have a lot of our more prospective data. Do you think that using this retrospective data that you both presented is enough to support the use for Alteplase or Tenecteplase in this patient population?
Yes, I can take this one first. So I think it's a little concerning that even with retrospective data, we are seeing some higher bleed rates, major and minor bleed rates. Specifically, the PITHO trial saw increases in minor bleeding too, which is not as severe, but something to consider when deciding to use this high-risk medication. So while it's not the best information, it is, what we have to go on. And given those risks, I think even in the swing towards higher bleed rates with Tenecteplase is hesitation for me enough to keep with Alteplase.
Yeah, and I think that's definitely a fair point. But I mean, given again, like in a lot of our disease states, most of our studies are retrospective in nature, just because these drug companies aren't always going to put the money out to support some of these trials. So I think that's, again, kind of the data we have to go with. I think there is maybe some room to kind of figure out the optimal dosing and maybe the preferred patient population for PE, whether that's with Alteplase or Tenecteplase. I do think there's kind of enough data to support potentially using Tenecteplase for these patients.
Great. And taking some questions from the chat, question for Dr. Pettit was, what was the duration of CPR after thrombolytic administration? Was it similar between the two cohorts? And was this maybe a factor in the increased ROSC seen in the Tenecteplase group?
Yeah, that's a good question. I didn't see the authors commented on the duration of CPR, but as we know that's a hot debate in itself too, that the recommendation from guidelines is at least 30 minutes post-administration of Alteplase in massive PE, but that's a good question if, CPR wasn't continued for an ample amount of time and, people just didn't give the drug a chance to work, which is why rates of ROSC were lower in the Alteplase group. But that's a great question.
Okay. Any other questions for our presenters? And then we'll give them a couple minutes to provide their final thoughts. If not, I have more questions. I guess one additional question that I had was in terms of anticoagulation in these patients. I think both of you also presented a little bit on this as well. But what are your thoughts in terms of systemic anticoagulation in regards to either agent, Tenecteplase or Alteplase, when managing these patients with massive PE?
I mentioned earlier that given Tenecteplace's longer half-life, the drug might just be sticking around a little bit longer, so adding anticoagulation too soon might increase the risk of bleeding. And we don't really have any guideline recommendations on when to start anticoagulation with Tenecteplase use for massive pulmonary embolism, but it seems to be that patients or that investigators are following Alteplase guidelines with starting anticoagulation simultaneously, if not after the thrombolytic infusion. And I'm not quite sure how that factors in, but just theoretically might be more risk of bleed upfront earlier on after thrombolytic administration.
One additional question that we got in terms of logistics. And so for those EDs or practice sites that don't have 24/7 pharmacy coverage, would you recommend one agent over the other? Any concerns with mixing, dosing, et cetera?
I think if you really have, no ED coverage 24 hours, I think having one agent on formulary is definitely going to be key to probably try and prevent any dosing errors. I think potentially if you have Tenecteplase, again, that dosing is a little bit simpler. There's potentially no math with your dosing based on weight. Whereas Alteplase, again, you have multiple different dosing regimens that you could be utilized. And so trying to figure out which dosing scheme is going to be best for that patient could potentially bring up some risk. Whereas Tenecteplase, it's just our one dose based on weight. We don't have all these different dosing schemes to think about.
I'll argue and say that there's no weight consideration for Alteplase. It's just more a matter of bolus, no bolus, half dose or not, which is the same no matter what the patient, how much they weigh. I also think that with the infusion administration offers a benefit that if you do notice bleeding, you can turn off the infusion, and given its shorter half-life, can maybe get a handle on the bleeding incidence earlier on, and potentially a shorter duration of bleeding, although that's not proven in any literature yet, but just something that you can quick turn off versus waiting for the drug to wash out with its long half-life.
One general question that was added to the chat was there's any consideration in terms of duration of CPR after thrombolysis with Alteplase or Tenecteplase, and if that plays into anything clinically with deciding whether to have both.
Necessarily kind of just on the data that we've presented that really either agent should differentiate time for CPR. I don't necessarily think the half-life plays into that. I think it's more just getting the fibrinolytic or getting the agent circulated. And so I don't know that either agent would really influence kind of how long we're doing CPR in these patients. I would about at least 15 to 20 minutes for whichever agent we're utilizing.
I would agree. I don't know the data if it makes sense. The longer the duration maybe of CPR, maybe better outcomes, but at least people putting in the chat 15 to 20 minutes minimum for CPR is what we practice at our institution here.
Thank you, ladies, for taking the time to present those two articles. You guys did a really awesome job. Thank you, Dr. Judah Brown, for moderating today's event. I'm really glad that we had the chance to bring ACCP and AMP together to be able to put on such a successful webinar today. We had over 120 people in this chat room, which was really awesome, knowing that we're all probably caught in the midst of a crazy boarding season in the ED. So thank you all for coming today. I wanted to put out a plug, just a reminder to join AMP if you haven't already. Join ACCP as well. Our AMP conference will be in conjunction with SAEM's conference that is coming in May. So the entire SAEM conference will take place from May 13th to the 16th with AMP Pharmergency specific programming on the first 2 days. So that'll be May 13th from 1 to 5 p.m. and May 14th from 11 to 3 p.m. So again, thank you all so much for coming. I'm looking forward to networking with all of you as we move on into 2025, and let's get amped up for a great year. So thank you all.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.